All right, bringing us home, our two fellows. Nadeen, I know you have something good, bad, and ugly.
All right, good afternoon, everyone. We'll do some MitraClip cases, the good, the bad, and the ugly. We'll start with the ugly and save the
Those
best
are
for
never
last.
bad and ugly.
All right, we'll start with the ugly case. So this is a 53-year-old gentleman who came in with dyspnea, extensive medical history of cancer with mantle radiation, COPD, requiring BiPAP. So we got a transthoracic echo initially, and on the peristernal lung axis view, you notice that the LV systolic function is depressed, and there's a very eccentric posterior directed mitral regurgitation jet. We can also appreciate that on the apical views. It's hard to tell the exact mechanism of the mitral regurgitation. Even if you zoom in, it's very eccentric, posterior and lateral. In this case, we got a transesophageal echocardiogram, and there was biventricular dysfunction, mitral annular dilation. The posterior leaflet appeared tethered. And as we got more views, there appeared to be a Flail anterior leaflet. And we explained through that, and you can see the Flail part with the cord, leading to significant mitral regurgitation.
That's a lot of smoke in that area.
Mm-hmm.
The van is parked up behind my high school. That's when
Since the patient was a high surgical candidate patient, she was taken to the cath lab, and these were the baseline images. This is the 3D image showing the A3 Flail right here, with significant color, which is consistent with her severe mitral regurgitation. Hemodynamics at the beginning of the procedure, we checked the mean mitral valve gradient, and it was 2 millimeter. We checked the transgastric LVOT stroke volume and compared it to after we deployed the clip, and there was systolic flow reversal in the pulmonary vein, consistent with his severe mitral regurgitation. This was the transseptal part, and we usually do this about 4.5 centimeters above the mitral annular plane. And we use 3D to guide us through the transseptal puncture. We usually aim for the 11 o'clock. I really like this picture. And then we pass the catheter through the septum. We started with placement of clip number 1. We targeted the medial aspect since we had the Flail E3 segment. This clip shows the grasping of the anterior leaflet and the posterior leaflet with the deployment of the clip. After the first clip is deployed medially, we check for color, and we notice that there's still significant color lateral to the clip. So there's still significant mitral regurgitation laterally. Moving on to clip number 2, we place this more laterally at A2 P2 junction. Deployed it, and the MR appeared to have improved. We get our 3D pictures and our 3D color, but when we got the 3D color, there was more significant color regurgitation compared to what we expected from the 2D. So we went back to our 2D picture.
But can I ask a question as you go through? Why did you go so far lateral in the middle? It seemed like everything was coming out of that kind of medial puncture. Why go all the way over there? What was the thought process?
I mean, I can't remember if we can go back, but I think even though it seemed medial, it was a pretty wide jet. And sometimes we don't want to get too close to it because we can knock off the first clip, particularly this one was in a little bit of a tenuous spot. There's medial clips are sometimes twisted and not totally coaxial with the two leaflets. So I think that was probably thinking just move over a little bit. The truth is, I mean, we kind of have tried everything, and we can't predict, you know, how this is going to respond. The easiest thing to do is just go right down the middle and hopefully get rid of it.
Well, what happened was the 3D color after the first clip, this is a nice example of the MR whack-a-mole, because we started with a very, very medial jet, one clip, but then the jet moves more laterally. So the most of the flow was actually A2P2 after we put in the first clip. So therefore, the second clip was, you go where the money is, which is where the big jet is, second time. So the jet moves around as you deposit clips.
Well, look, now we're looking at the bad news.
This happens.
What do you notice on this view? So we had two clips. One was more medial, and it is this one right here, and the more lateral one. And you notice that the medial one is mobile, and it's only attached to the posterior leaflet. So we had a single leaflet attachment of the first clip. So now it's only holding on to the posterior leaflet, and it's moving freely. And again, significant regurgitation between the first clip and the second clip.
So now the MR has gone back medial.
And you can see that bottom clip, how much it's moving. That's a hint that it's a single leaflet detachment compared to the one on top, which is very stable. So this is a problem.
Doesn't always look.
He'll fix it. Give me a couple of slides. It'll be fixed. So we go for clip number 3. And we go to the area between the first clip and the second clip where the MR was originating. We grasp the leaflets, deploy the clip, and the MR improved. And we can see clip 1, 2, and 3. The MR was moderate at the very end with partial stabilization of the partially detached clip. Follow-up hemodynamics, the mean gradient in the presence of the 3 clips was only 3, so that's a good thing. There was increase in the LVOT stroke volume, and we went from a systolic reversal in the pulmonary veins to systolic blunting. So we see that nice upright S wave right here.
Good, and it's important to secure those single leaflet detachments or they can embolize. So we can't just leave that.
Towards the end, there was an iatrogenic ASD, but it was predominantly left to right, so we didn't have to close it. And you can see it here on 3D.
So what was your mean grade in that again?
3.
3.
Mm-hmm.
So you always talk about how you raise your flow and so you walk around. Is there anything you guys do to stress the valve if you get higher? What's the most you'll take, Colin, before you
I mean, we've been, right now, it's kind of like, depending on the heart rate, 6 is kind of our cutoff. We don't want to go above 6, ideally 4 or less. But sometimes we do. We'll pick up the heart rate, give him something to increase his heart rate.
So this was a case of an immediate single leaflet detachment. Single leaflet detachment usually occurs in the first month after a clip deployment. It was reported in 5% of patients enrolled in the Everest 2 trial and about 0.7% in the COAP trial. This is along the same theme, but this patient, who's a 65-year-old high surgical risk patient, had 2 MitraClips 2 months prior to presenting with dyspnea and heart failure symptoms. He had a TEE, and you can see the more lateral clip is attached to both leaflets, but the more lateral clip is only attached to the anterior leaflet this time, with significant mitral regurgitation. So this is the more medial clip. This is a tissue bridge, and this is the lateral clip that's partially detached, again with significant mitral regurgitation. So we took this patient to the cath lab, and he had a 3rd clip placement lateral to the partially detached clip. We ended up with a triple orifice mitral valve, acceptable gradients, and mild mitral regurgitation. So again, a bad case, but ended up in a good way. And finally, a good case because it's getting towards the end and we can't lose hope and faith in the MitraClip, especially with the co-op trial. This is a 76-year-old female with fluid overload symptoms. Came in and had a transthoracic echocardiogram. And on the peristernal lung axis view, you see the clear prolapse of the posterior leaflet. Significant mitral regurgitation, difficult to appreciate on this view. We got a transesophageal echocardiogram, and you can see the prolapse leaflet with a flail and a ruptured cord. And again, significant MR going through that flail gap. Was taken to the cath lab, and 3D images confirmed the presence of the P2 flail. You can see it going into the left atrium. This is the left atrium. This is the aortic valve. It should be flipped. Had the clip positioned in the A2-P2 gap. This is the grasping process. The clip deployment. Mild to moderate residual mitral regurgitation at the very end. And we always check the hemodynamics to make sure we have a good outcome. So this is the initial pulmonary venous flow with systolic flow reversal, and we ended up with an S wave, a systolic wave. And there was an increase in the LVOT stroke volume post-deployment compared to pre-deployment. And the numbers don't lie. So this is our pre-clip left atrial pressure, with a left atrial pressure of 58. And post-deployment, it went down to 16.
Bless you. Yeah. I mean, those SLDAs were odd. We hadn't had one in a while. And it turns out with these new clips that have come out, there are a couple, this wasn't a unique problem to us. And they sort of went back and changed some of the technique as far as how we deploy the clip, because basically the interaction between the gripper and the clip arm was getting disrupted if we were deploying them the same way as the old valve. So hopefully that doesn't happen anymore.
I would write those off as part of the new device learning curve.
Yeah.
That was really the first month that we transitioned to the XTR, and all of a sudden we got 2 SLDs when we hadn't had one in probably a year or two.
Yeah.
But yeah, great cases.
All right.
Great. Thanks, Nadeen.
Thank you.
That was great.